All right, let's go ahead and get started here. Just taking a look. Well, we're going to get started. Anyone here new to HIE? Good, good. All right. I'm Chris Ford. Yeah, that was my dad up there a little bit ago. So it's always daunting to have your dad or family member in the room while you're doing something like this, but it's also just as daunting to have your boss in the room here presenting with you. So getting it from both sides. But my name's Chris Ford, account manager for business development for our team, for our organization. So we try to help get folks acclimated to what HIE is and build that relationship. George Bozniak.
Yep. Thank you all for being here this morning. George Bozniak, I'm our Director of Sales and Business Development at Great Lakes Health Connect. So I oversee all of our community implementation consultants, community outreach, marketing, communication. My team put together the conference today. Also kind of handle all our legal and financial stuff, and been with the organization for almost 5 years. So basically right about the same year it started. So thank you again. Look forward to the conversation.
A couple things. I want to keep this informal. I feel like I want to take off my jacket and get rid of the mic just so I can sit and we can talk with you guys instead of just making this a presentation. So ask questions, interrupt. George and I are pretty approachable and pretty much level set. So if you guys have questions, just raise your hand. If you want to just interrupt me, feel free. Couple things. There's cards in the middle of the tables. So what those are, please fill them out. We have a town hall session later on in the day where it's going to be a forum of our staff that will take any questions. So love to have your input, love to have those filled out and brought there so we actually have questions to answer that aren't canned. So as you're hearing more and more about 101 HIE 101, whatever you want to call it, that's the place for it. Or if you have something that you want to know information just about what we do further and want our time, that's the way to get a hold of us too after the conference. Okay. Planning on going about 35 minutes, question answers throughout the time and after. So if you have some then. And the breakouts. If you're feeling like this is, along the day and you're signed up for one event and you want to go to one of the other ones because you didn't realize that it offered that, you feel free to jump ship. That's okay. We're not going to hold you to it. Let's see if I can. Might have to do this manually. All right. So the government has a definition of HIE. Electronic health information exchange allows doctors, nurses, pharmacists, and other healthcare providers and patients to appropriately access and securely share a patient's vital medical information electronically, improving speed, quality, safety, and cost of patient care. We wanted to go into this to say what are others' definitions of HIE. We heard a little bit about it this morning from the panel, talking more about population health, not just health systems, doctors' offices, behavioral health, community programs. We wanted to kind of front load this presentation with the kind of the standard HIE perspectives. There's entities that have HIE defined as that, pretty much clear as mud. Some objectives for today's slide deck here in our presentation or talk. Improve healthcare data delivery outcomes, enhance patient workflow efficiencies. That was brought up this morning. Drilling down and hitting workflow operations, whatever organization you're in. Connect networks, very much relevant when you're talking ACOs, you're talking physician health organizations, you're talking hospitals, doctors, the whole gamut of organizations providing care. Meaningful use requirements. There's a presentation right following this one with Bruce Mackay from Alterum to kind of talk about what are the changes in meaningful use, what's going on now, what's going on later, what are the proposed ideas, because meaningful use is affecting everybody. And then facilitate care-connected communities. One of the things that our Doug Diesman, who was facilitating this morning, the key thing is to make sure that we're fostering a care-connected environment. As my dad said earlier, HIE defined, we have us in the middle, not to insinuate that we need to be in the middle, but kind of as that, how do we, as we gather data, how do we share it? How do we get access to it? I'm a behavioral health provider, I can't give you my information. True, but we can have behavioral health access that information. So when that behavioral health organization gets that patient and has no idea what kind of labs have been done, talk about the opioid problem. The ability to go check into our database and say, all right, I've seen Chris has been at 5 different EDs over the past week and a half. We got a complex situation going on. So the idea of getting all the different groups here to share from a standpoint of information, transportation was brought up this morning, some of the social services. We got a whole lot of money going into clinical, to hospitals, doctor's office, into the clinical side. What about the social services? So again, the patients are transient. You have the frail patients all the way down to the peds. How do we get that information shared? This is a little bit about us. Doug mentioned a little bit this morning, but we're statewide. Even at that matter, the borders don't prohibit us from doing things. If the patient's care warrants crossing the borders, that's where we'll go as well. Talking about different EMRs this morning as well. There are about 50, I'd say it's more than 50 at this point, EMRs that we work with, that we've partnered with. There are some that are not charging for interfaces. So how do we get folks that are? How do we get folks that are not? We really navigate that world pretty decently. As Doug mentioned, it's not necessarily a negative relationship. We just worked with them quite frequently. Thus the integration of 50 plus EMRs. So sometimes we can be helpful because we know folks that have worked with folks in the EMRs. So again, if questions like that come up, feel free to reach out. Bridging silos, a whole lot of silos going on. We broached all those this morning. You throw the payers in, you throw a lot of different pieces of that. So our concept is beyond the 4 walls. What needs to be addressed for those patients? And then solving real problems. So folks, from access to information, if we have an organization that wants information from that hospital, how do we help that conversation get to the hospital so that hospital knows that these groups have been asking for their information in the statewide repository? How do we get some of those silos? George is very good at reminding the team, we don't want to provide value if the customer doesn't have any value there. We're not going to do it if there's no value. So often we come to the customer and say, what are you dealing with here? The state says you need information, go here. What does that even look like? So we do a lot of blazing the trail, a lot of niche, if you will, in healthcare, and that's
Systems, hospital, government? A little bit. Where is everybody else from? Yeah, where are you from? What is everybody from? What?
Payer.
Payer?
Yeah.
Okay. Okay. IT? Independent lab? Not independent lab? What is CPA Lab Network?
Like we manage the lab network for outpatient services from 120 hospitals in Michigan.
Okay.
They're JV with us.
Oh, then could have just said that. I know who that is.
I can speaking engagements and I'm a consultant. I've been trying to engage with Great Lakes for a long time.
Great.
Got your card today.
Thanks for being there. Anyone over here that I missed on a unique facility they're from? Great. That just gives us an idea. And what Chris means by solving real world problems and who we are, we work for our members and for our customers out in the community. We don't have a set of these are requirements that we have that you must do. We really have these sort of forums and go out and meet with providers and other groups and say, what are your pain points and can we help solve those in a efficient, effective, priced right way to be able to move forward. So that's what it means when we're solving real world problems, is that we don't have a, here's the technical pie in the sky that you must do that'll solve all your problems, because that doesn't exist. What we do have is a lot of great partners and a lot of great networks that we've built across the state where we can bridge those communication barriers and implement the technology needed to be able to put information at the point of care to solve those problems. So that may be a little bit of differentiation on us and who we work for, and it's really the provider community across Michigan.
Absolutely. Even on top of that, a lot of mention was made of grants this morning. We're not grant funded. We're participation membership funded. So our members are the ones funding us for this. So something to keep, yeah.
Who are your members funding this? Hospitals?
Hospitals, yep. So traditionally, this organization was built on the premise that the hospitals were not going to have the independent physician offices have to pay their own way for this. hospitals were going to cover that. And then as we've expanded to the different industries in healthcare, we have membership rates for different groups throughout. So whether you're CMH, whether you're a health department, behavioral health, yeah. Covered it, yeah. So again, when you think of grants run out. Then what? And so we wanted to make sure that there was a solidification involved with perspective of those that are members. We do a lot of different things, and I can't remember if the slide deck goes into that, but we send stuff to the state of Michigan for groups. If you need to get your immunizations, reportable labs, syndromic surveillance, you'll go through us to do that. Closed loop referral app. We got a lot of different things that are helping those use cases. So members could be a multitude of different groups. Good question. Bottom line kind of goes to what Doug talked about this morning. Create care-connected communities across Michigan and beyond. Basically wanting that patient's information accessible when needed. Okay. Participants, I mentioned some of these already. Home health, hospice, skilled nursing, continuing care is all that side of the industry is very now relevant that we're trying to work with. Labs, long-term care, rehab, skilled nursing, as mentioned. This is some of the demographics about us. Again, 129 hospitals out of 130 plus in the state. 90% of the acute beds covered. Participants, I think it's over 4,000 now, I'm guessing, relatively. Again, participant could be any of those mentioned before. 6 million unique patients. So we have a longitudinal record, a statewide repository. I want to look up Chris Ford and see what folks are contributing to. We have over 6 million unique patients that are able to be looked up. If you think about that, Michigan's from the 10 to 12 million, I believe.
9 million.
9 million? Okay. That's pretty relevant in terms of having access to that information when that patient shows up. 95% of the information flowing to the state goes through us. So if you think about immunizations, syndromic surveillance, reportable labs, those things you are required to submit tied to reimbursement. And then a billion messages per year. So that's pretty significant. The different challenges that HIEs face, we just mentioned some of the financial if you're grant funded, but market dynamics are ever changing. You have hospitals that are joining, merging other hospitals. You have dynamics there. One size does not fit all, where I think you can think of us as a very customized, fluid shop where we may run into a use case from one of you that we didn't expect to know that existed yet. One of our things is to create a statement of work or a contract around that so we can help you meet your needs, but also we can turn around and help others that are having that same issue. The provider's culture is unique. That is definitely the case when you're talking about all the different providers that we talked about this morning. And workflow integration is the key. It's one thing to give a technology. Deployment, training, operationalize what's going on the non-technical side. One of the questions we ask when we're putting one of our solutions into an office is, what did you do without this solution? Let's try to marry the processes a little bit against the solutions that we provide. And also, again, not recreate those wheels. So challenges are ever present. Some of these are regarding breaching. You know, you hear breaches across the country, security. You hear about the finance, HIEs shutting down because of the grants or lack of their grants. Innovation. So you have a lot of different obstacles. The government, I heard this morning, loud and clear. I mean, you have a lot of different aspects of how do we standardize some of this. So it's not just, let's talk about the state, let's talk about regional, let's talk about national. I think day one, Doug said we have to lay our tracks first. So let's do our day-to-day that we can accomplish that, then we can look beyond. That is a little screenshot heat map, is what we call it internally, of the participating hospital locations in Michigan. So you can see it's pretty much across the entire state there. We have a couple presences up north in the UP. Again, every hospital may be doing different things with us. I mentioned the statewide repository. Not every hospital is contributing to that yet. There are some that are just going to contribute their information to get it up to the state. There are some that sign up just because that's all they want to do or are able to do at that time. Circle back around because either providers in the community said, hey, I want that hospital's information. A hospital doesn't have to build a point-to-point interface. It's a lot easier to build it once to us and not have them have to deal with all those additional types of information. Participants, mentioned the 4,000 plus groups across the state. And again, that's a heat map of presence of where they're located. Yeah. Any questions? Kind of blitzing through this. Yeah.
Do you have a couple things I wondered about? You had a list of the participating EMRs and also a list of the hospitals that are participating, especially like up north, like, Northern Michigan, down Clarendon. But I would think that would be really a lot easier to
Yep.
go to my doctors up there if they knew that they had access to it.
Yeah, so all of that is available on our website, but to really quickly answer you on the hospital, every single hospital or system in the Lower Peninsula besides DMC and Bronson work with us. Everyone else does.
So can you explain to me how it seems like, okay, I participate with the HIE, but I would think that that would be an open menu of things. So you go and you pick a la carte, like I only want to do this or I don't want to do this. What's the barrier to saying do it all? If you're sending data, isn't it a one-way flow?
Yeah.
What's the reluctance or the difficulty?
So when you say barrier to do it all, do you mean receive data from all of the different sources that are giving it to us, or to do all of the different types of tools that we have available?
All the different tools you have available.
So there's really no barriers to that on our end. We do have providers and groups that do everything from we send all of their meaningful use, we deliver them results from all of their applicable hospitals, they use the referral tool, they use Viper, they have a direct address through us, and we're working with them on coordinating care with other groups. So there's nothing really that would hold an individual or a group back on that. Obviously, if an office doesn't have an EMR, we can't build an interface to their EMR, but we can give them an inbox and we can deliver it electronically so they're not getting faxes. So there's a little bit of a technology barrier. If you're an owned physician of one of those systems that is non-participating, then that is a barrier. We need to have those BAA. The requirement is that if you are an owned physician, that your parent organization is a member and participating at the same level as everyone else. If you're independent, we obviously work through that with all of those different independent docs too. So.
Do you have any statistics on, like, are most of the users just getting ADT feeds, or how many people are actually using the referral component of it? That would be.
Yeah, so there's about 1,250 referral offices. I actually didn't look on Monday what the new number was.
Roughly that.
So yeah, so we got about 1,250 different locations using the referral tool today, sending just under 20,000 unique patients electronically, tracking every month. Of that 4,000, I think that we are doing 1,200 offices for immunizations, about results out to 2,000, 3,000 offices now. So a lot of those are doing 1, 2, or 3, or all of those across the board, depending on what their needs are. And I believe most of that's available on our website. We don't have here's a list of every office that we send results to, just because that's can get used for marketing and for other purposes that we're really not there for. But certainly if someone wants to know if someone else is participating or what they're working on, we could do that. Often for PO or a PHO group, if a provider's member there, we would work with them and have a big long spreadsheet of every office on one side and a column of every service we can provide across the top, and have blank, yellow, or green. Are we doing it? Are they using it now? Are we building it? Or have they not talked to us? So you can kind of fill in that map for yourself. And we can do that for individual offices, obviously, too. I think there was another question back there.
Yeah, I'm from one of those unfortunate offices with an EMR that doesn't currently have a connection or a relationship with you.
What EMR is that? Just
Advanced MD.
okay.
You've never heard of it, have you?
That's new to me. Yes, which is actually of the 50 some that we work with. I'm
Right.
surprised I haven't, but okay.
So, well, it's a pretty low cost entry for an easy to use system. So my question is, I'm from a peds clinic, so I have 6 peds doctors, and we don't have a lot of high usage. We have mostly well patients. So labs don't love us, hospitals don't love us. We don't generate a lot of money. Nobody cares about kids. Okay, so sorry. But my question is, Susan knows me, so she's laughing. How do you get connected with an EMR? Like, what would make you talk to an EMR
Yeah.
get connected?
So,
Should I be monkey in the middle, be like, hey guys,
yeah.
talk?
So here's the process. You're Bloomfield, right?
Yeah, what's Bloomfield?
Yep. So for West Bloomfield, either Joe or Greg would come out and kind of sit down with you, who's one of our implementation field people, and say, all right, we'll get your EMR. We know who it is. What facilities do you want to get your lab results from? So you use, what systems do you normally mostly work with?
Beaumont.
Okay. So Beaumont and St. John's. Both of those are participating and sending results to us. We then would take that and say, all right, our Beaumont and St. John's person, here's these providers in this PD's office. We match it up with the hospital's independent codes that they have for each of their providers. Then we would go back to your EMR and we would see how much it costs your EMR to you to build that interface. We don't charge for that. We'll route that data to you. But then we have Paul, who isn't here, Paul Riker and Drew, who are also giving presentations later today. Both of them are interface specialists. They would work with whoever your point person at MedMD?
Advanced.
Advanced MD. So whoever your technical point person there is, and when they have access to those result feeds, they would start sending them and testing those and making sure they show up inside of your EMR properly. That's really pretty much what it is. So if you would like, yep, you would just reach out to us and we will hold your hand through the whole thing.
Are you doing immunizations with us currently?
We have immunization.
Going to the state? I mean, do you have that done through us currently?
Yeah.
Okay, because
So-
there's also the immunization query that may or may not be available for advance to keep you basically in your EMR to check to see if those immunizations were given to that new PED that shows up.
Okay.
So-
So I'm asking not just for myself,
Mm-hmm.
but I'm in several groups of PEDS managers,
Yep.
administrators, and we're all struggling to get in the game. So.
It is, and you're not the only group that does that. I mean, you at least are a provider. I mean, there's groups that are outside of that provider network where there's no provider code and that they need their results, and then it's even more complicated as to how we do it. But really, we try to have individuals locally in every community that can come out and meet with you personally and really fill out what we need to do. Then we hand it off to our very bright technical people, and they work directly with your EMR. Certainly, you'll have to be involved, but we try to make sure it's as least burdensome on you as possible and as cost effective as possible. So tell everyone else we're more than happy to go out and sit down and meet you at your location and start that process.
And you even mentioned you're part of a group of docs, even if it's something where you put something together and have us join and just talk to y'all. We're finding that often folks talking with each other with us is very effective. We can always cold call or discuss things. I mean, we're trained to do that too, but it's often parties talking with each other with us sort of helps broker some of that.
Any other questions before we move on? I feel like this side of the house has a bunch of questions that they haven't gotten out yet. We're waiting for the second half rush. Good deal.
Right. Okay. You want to do this one?
Yeah, so this, which is really difficult to see because it's dark, so that's disappointing. But this is our heat map for where those 6.5 million patients are located in that community record that's available out to providers. So why is this important? Well, if you're in Flint and you're wondering what percentage of the population is out there. So if I'm going to look at this community record, am I going to find the patient that I'm looking for? Well, in certain areas, we have a vast majority. So for Flint, all of Genesis, all of McLaren, and all of Hurley's data is contributed. So any inpatient result from any of those facilities is all there and attached to one unique patient. So there, if you could see it better, I'll have to yell at the colors, but there's heat map there where there would be a hot spot. Southeast Michigan, so St. John's, U of M, Mercy Memorial Monroe, Trinity, those are also all contributors, so there's a good chunk of population there. Lansing, Sparrow's a contributor. For Northern Michigan, all of the Munson facilities contribute and store their data. For West Michigan, Metro, Spectrum, all of them store their data. Middle of the state, Mid-Michigan, is also a contributor. So when we say that there's 6.5 million unique patients in that record, a vast majority of that comes from those inpatient facilities that are contributing their laboratory radiology, ADT, transcribed document, end-of-life care documents, CCDs, where we're attributing those to one unique patient. So that if you're, George Bozniak and you're at St. John's here in Novi, and then you go up to Munson, and that result comes from Munson where you break your leg or something like that happens, it would be attached to the same individual so that when you go back to your primary care doc, they can see what happened no matter where you're at across the network in the state, just like you were there. We're building that as a single sign-on into EMRs, so a couple of the facilities, U of M, Trinity, Spectrum, PCE, BHPI, who was up here earlier, uses them, whereas they pull up an individual in their EMR, little tab on the top right, pull down that community record of whatever else there is out there across the network. One click, you can show everything that's being contributed from everyone else, all attributed into one spot where you can match and get that whole picture. Yeah, go ahead.
Are you seeing the facilities record itself, or are you compiling and abstracting and putting it into the Viper's own?
Yep, it is its own viewer. We're taking the HL7 raw data from them, and then it does get formatted, and there's actually, I believe this afternoon, a couple Viper, or there might even be one this morning where there'll be an actual Viper demo where you can see what the portal looks like. But really, it's similar to what an EMR looks like. There's, on the left side, the demographic data. There's an encounters tab where all of this person showed up at this date and time in this location with this complaint, and then there's a results tab. If they had lab results, it would be set in there by encounter or by date. If there's transcribed radiology reports, those are there. If there's a full CCD for that individual, that's all in separate tabs. So it's laid out and matched there. When you click on them first, you see them, you can see how many different sources, how many different dates, where they're getting that information from for those individuals. So it gives you a snapshot of here's what's happened, here's where they've been, here's their current demographics, here's their results. Is there any special care plan documents attached to them that you can put together?
That class is at 11 o'clock in room 101. Feel free to transient yourself over there.
Yeah, so when Chris said we don't have all contributing today, there are 56, Bev will yell at me if I don't know the exact number, source systems contributing to that virtual patient record. We are working very diligently with many different types of groups to add ambulatory. We're adding ambulatory locations. Quite a few of our FQHCs are signed up, and we've got 3 or 4 in the build stage. Skilled nursing long-term care facilities adding their ADT and their CCD documents to where those would be attached to that individual. Home health, we're working with a couple of home health agencies, and there's a presentation later today on how we're connecting those and adding that as a result into Viper. Social service agencies, so if they have a special care plan for an individual, how do we make sure that that care plan is available if an individual shows up in an emergency department? Those sort of things are also being added there. Big national laboratories, so LabCorp and Quest, both all have connections to this. So if you are a provider and you order from those national based laboratories, we have a kind of a single page release form where all of those lab results then can be contributed to that community record and have that added there. So that's where that 6.5 million comes from. Geographically, it's spread across kind of those urban areas that I discussed before. But you're looking at over 66, 70% of the population of Michigan currently by the 9 million to 6+ million sitting in one spot today. So basically, we haven't went anywhere where they haven't went through at least 2 or 3 patients and found data on someone where they're like, I didn't know that person went there. Why would they go there? What were they doing over here? And ties into really earlier when we were talking about, how are we dealing with the PCMH? How are we creating a care connect community? And if you're taking responsibility for patients across the community financially, you've got to know where they're going. You have to have that information. You have to be able to see and have great visibility into where they are. And that can't be limited by EMRs. So that's what this tool is intended to be, really pushing the access and having that roll out. But any other Viper? Yeah, go ahead.
So I'm from a payer, and we obviously don't have electronic medical records. But obviously we have patients and care managers, and we hear about them and where they go and how it can affect their care. We have a care management system. Is there any
Yep.
feasibility?
So there is. We actually have care managers for certain payers today that use this tool. They'll get an ADT notification, multiple different ways that can be delivered, either through us based on your payer code or based on an attribution file that runs up through the state. So then what they do is they take that and they pull up, because they're not going to have connections out to every single inpatient facility where this patient may have showed up, but they can pull them up in Viper and one click, see them, here's that person, and then they can coordinate that send that information, move that CCD if they want. But yes, we do have payer-based care managers that are using the tool to be able to coordinate care for their patients.
So can you get more than just the ADT? Can you get the CC?
So,
CCR?
technically, there's no reason we can't. It's matching it up to having something on that CCD that says it needs to go to you. Usually there's a provider code or some other information, and there's not necessarily the care manager's code or the payer's code on there. But what you can do is log into Viper or have access to that Viper, and all of that data would be there. That CCD will be there. And you can click and create a PDF CCD from all of the data that's in there and available on that person and say, print to PDF, and then you have a CCD either electronically that you can store in your care management system, or if you need a paper-based for some reason, that's also available. So yeah, we absolutely get that if you get an ADT, something happens somewhere at a certain time, and then you're kind of a little bit left in the dark. So that's the intention is, here's the flag, let you know what you need to look at, and then give you a tool, the most robust tool that's available out there to be able to see what happened to them across the community.
Okay, so Viper would be the.
Yeah.
It is the largest repository of longitudinal patient record that we have for the state. Yep.
And just to go back to the pediatric side of life, there's a group of pediatricians on the west side that are using Viper to contribute all their asthma action plans. So when those patients show up in the pediatric hospital, these independent offices not owned by the hospital, they're contributing those there. That medical director of that initiative was just adamant about, I want our kids' information there when they present. So again, thinking of that comprehensive, I want to contribute care plans, advanced care directives, asthma action plans. We have pain clinics that are going to be contributing their care plans. So that's centralized, as George said. Again, reducing silos too as much as possible. So.
So I'll break those up into 3 separate categories. So for those urgent cares that are attached to systems, like that would be on that Serpent EMR, they would have access to this community record, and those records from that urgent care site that are associated with the health system would be put in here. So they do have availability there, just like they would have availability in the core central emergency department. If they're an independent, and I don't know how many independent urgent cares are out there, that would be a different build. We would have to reach out to them, and I could be wrong, but I don't know offhand any independent urgent care facilities that are out there, and I certainly don't know any that are contributing to us. So that would be one separate. The next one, I think that you're talking about telemedicine, maybe? So yep, we do have telemedicine groups that we work with, and obviously, how is this valuable if someone's jumping in or calling in, and maybe it's a new patient to you or someone you're certainly not used to treating. You want to get as much information on that individual as possible, and having that community record is a great way to do it. Also, a lot of telemedicines don't have a standard EMR. They're small, getting started, don't have that robust HL7 data. So we're looking to take out kind of package transcribed documents and CCDs with one telemedicine group now, and have it so that those are attached back to that community record, so they're viewable when that patient would go back to their primary care or when they would show up to a inpatient facility. So yes, for 2. The last one, the CVSs, the Walgreens of the world, we have had discussions with them. They are big, and we do have some pilot things that we are working out with them. I would think that that's coming, but today, no. There's no real direct connection or tangible data coming out of those private companies to us. Ready?
Got a couple more minutes here. I think there's 2 slides left, so I'll just get through those. And again, if you have questions that are just coming up now, just raise your hand, let us know. Doug, who was up earlier, kind of facilitating the panel, just a perspective of the future with HIE. The future of healthcare information exchange is not about technology for technology's sake. Rather, it's about connecting community in meaningful ways that contribute to improved access, care, and quality of life. Again, that's something that we drive to organizationally. We are a nonprofit, so it's about trying to make what matters. We talk about use cases daily. And these 4 pieces here, sustainability, we try to make it sustainable. I don't think we've turned anyone away. So we try to meet folks at their doorstep. That also encompasses some of these EMR vendors. I mean, everyone has to try to, questions asked again and again this morning, who's going to pay for it? I don't think there's an answer yet, but we still have to work toward that ever-changing market. Consolidation, as things change, as organizations join other organizations, as organizations leave other organizations. Some payer situations. I mean, you have a lot of moving parts. So that leads to the interoperability. Interoperability is a very interesting word. It means a lot of different things to a lot of different people. Interoperability could mean, my dad was talking about Spectrum and their Epic into the house, 4 walls. Good for Spectrum, trying to get their 4 walls straight. It's everything outside of that. So if we can learn to think about outside of our own 4 walls, how do we affect, so we're not becoming a silo, good that you're improving inside, but how do you affect care outside? And triple aim. I'm going to read you Wikipedia's version of what this is because I wanted to look it up because I always hear triple aim thrown out there. And interesting how, see if it relates to this morning's conversations, reduce the cost of healthcare. It's a big piece of it. Improve health of population. Again, that was big this morning's discussion. And then improve patient experience of care, whether that's quality, which is basically inclusive of quality and satisfaction. So again, I think all of those are transparent in this morning's conversation. So it was interesting to get Wikipedia's translation of triple aim. I think that's it for the presentation itself. We have about 7 minutes, if that. Any questions or thoughts or ideas? Open to it. You have us here for that time. Yeah.
I heard you throw in a couple of buzzwords, your BAs and things like that. So, nobody's mentioned about your compliance. Do you have a compliance program that you're set up so you have your securities, with your security, with your IT, for all of this dumping stuff?
Yeah, we do. And actually, when's the privacy security presentation?
Same time as Viper, but room 105A.
Yeah, I did see that.
Okay.
Yep, so we do have that. Obviously, BAs are standard, and everyone here probably has seen one executed, dozen of them or thousands of them like we have. So those are pretty common things. For the community record, we do have available specific legal language that we give out and distribute to all of our contributors that is a notification. In reality, almost everyone is contributing their data before they give it to us to some other source. It's getting up to a payer, it's being reported to the state. In some way, shape, or form, even without us, that data is being moved somewhere that's visible outside of maybe what normal their care is. So those releases are already in there often. If not, we have that, and we have that fully approved language that we're willing to give out to everyone. Every time someone has the tool, there is extensive training that goes in. But usually someone doesn't get the tool unless they are a business associate and are required to do HIPAA training in-house. They're used to using their EMR. Anyone who uses an EMR knows I'm allowed to look at this person because I'm treating them. I'm not allowed to look at my aunt. I'm not allowed to look at a famous person. I'm not allowed to search around willy-nilly. And that translates exactly through to us. All of those same rules and requirements applied. Individual unique usernames and passwords are always assigned, always tracked. We have the ability in-house to track all of every user's login, what they look at, what they see. There's specific algorithms that run in the background, like last name matching, pretty common one. OBs looking up males. Those are pretty common ones that people look at. Peds looking up geriatrics, those sort of things where we would be like, these things don't match. There's got to be a reason as to why. And we have our privacy security officer that works with office manager or whoever is the point person at those facilities and say, here's a possible occurrence and kind of work through the process then. So yes, all of that is in place and pretty robustly done.
Yeah, another thing to think about too is traditionally, again, take the technology out. How are these folks getting that information now? I got to fax a form over to Henry Ford, or I got to fax a form to Beaumont. and I don't know how timely that response will be that I will get what I need. And so the idea is the hospital's gone with this so that they don't have to deal with that risk and compliance, that they can come through us because all that information is there. So I know some hospitals base that on credentials for the providers and their staff. They have to get tested every quarter. You know, things like that where it may be a requirement of that hospital that gives hoops for these groups like yourselves for that information from that hospital at a lab. So yeah.
Yep, absolutely. Any of our tools, referrals, Inbox, Direct, Viper, with those contracts comes a certain, we'll come out and do a training. We try to come out and meet in person, basically as much as possible. There's a reason, we have 2 people based in Metro Detroit. We have 2 people based in Mid-Michigan. We have a person based in Flint, person in Northern, a couple people in West Michigan. It's because we want to be local. We believe that this is a local. We have to understand and come out and meet with you in person. So the discussion, the training, all of that, we certainly do in person, have that set up. We also do have online videos and trainings that can kind of walk you through that process on YouTube. So you can say, here's how I set up this username, here's how I log in and use this tool that's available to our members also. Yep, there absolutely are. So a couple of ways that we're kind of growing outside of the border. So we do work, and we are becoming eHealth certified, which is kind of that national health information network, or this CORE project, or whatever it's called now. Its name's changed multiple times. But basically the premise is that we will build to the national network, and we take data to a national standard so that we can query a national network, and that national network can query us and move back and forth. The kind of most prime example of that is the VA. The VA is connected to that. We'll be finishing that up here this fall, September, October, and we'll be able to query the VA and pull that data back down and deliver it to our members also. So we are building to that national standard there. Second, we do work with other peer organizations, HIEs, state-based, regionally based, even enterprise-based HIEs that are looking on kind of a Midwest pilot to be able to deliver those notifications outside of just the state border. Taking in ADT based on individual zip codes, matching those to what HIE is responsible for that zip code, and then delivering it back down to those providers based on that member file. So we do that. On the edges of the border, so like Indiana, Ohio, we work with Mercy Memorial Monroe, we work with Lakeland, so obviously there are providers in Indiana and Ohio, and today we do have actually some in Indiana, and we've had recently some in Ohio that are asking to be able to move that. There's nothing that binds us to just be geographically in Michigan, but like we said earlier, our job is to solve problems for our members and people that approach us in our communities. It would be a tough sell for me to say that I should go out and spend a lot of time in New Jersey and help build an exchange there, because I don't know how much that would help Michigan. So why would I spend time and energy doing that? Now, Toledo, Chicago, those sort of areas, yeah, I can see where we would certainly have a reason and why we would partner with some other groups there to be able to move that data the same as we could if you were moving it from Port Huron to Detroit. Should be able to work the same.
Snowbird's going south.
Yep.
I mean, you have the same use cases popping up from doctors' offices saying, I want my information for my patient that goes down there. So, yeah.
Anybody else? We do. So we do work with MyHIN. They are kind of the state level front door network. As you said, when we showed up there a little earlier, that a vast majority of the data that goes up to the state, we send them. So all those ADT messages, all of the immunization, all the reportable labs, all those syndromic messages, cancer registry, newborn screening, pulse ox, all of that stuff we send up from our members there. We do more use cases with MyHIN than anyone else. I think the difference there is that it is those use cases are presented down based on what state level needs are and some other incentives there, and we plug those in. We deliver ADT out, we deliver ADT up. We do common key use cases. We do basically all of that based on our members. But really, the difference there, and I have a MyHIN board member here, so I want to make sure that I'm not speaking out of turn, is we're really driven by you guys out in the community. If someone comes out and says, hey, we have this problem, can you solve it? Great example is One of our large systems in town had a social service agency that's using Salesforce to track the individuals that they're taking care of. And they have no way to be able to communicate that back to their care managers at the ACO level and have that available. So we're building a unique way to take out data from a non-healthcare system, package it in an HL7, and be able to deliver it through the healthcare network. Now, that's not necessarily something that's going to be a statewide service, and it's never going to be something that we're going to build and force everyone to do, but it solves a really core, unique problem here, and there's value to it for certain users. So that's sort of where we see ourselves fitting. We don't think that there's a great network in the sky that's going to solve everyone's problem. I don't think that the Sequoia project or connecting to the eHealth Exchange will solve everyone's problems, because there'll always be an EMR vendor that's a slightly unique and different. And there'll always be groups that have workflows that they want to do their own way and that they'll demand that it be that way, and it just doesn't quite work. So we see ourselves fitting at the, what's your real problem? Well, there's a reason why we want to be in the community. We want to know those unique community problems and be able to solve those given the talent and the people that we have and being out there. So that's what I would say the difference is. Our mission is really, are we moving forward healthcare and outcomes for our members? So we do absolutely work with them. We work with them more than any other group. The volume of data that we send up there is higher than anyone else. We also sit on their board too. So
I'm going to close this up. You can have a break here for about 15 minutes. Bruce Mackay from the Altair Institute is going to be talking about Meaningful Use 2016 in this room. So there's a couple other, if you look on your agenda, you'll see there are a few other presentations downstairs. Those are in the 4 rooms downstairs. So feel free to pull us aside if you need some more information from us, but thank you for your time for this.
thank you all.
Appreciate it.